Good evening. My name is Dr. Nadia Ovchinsky. I'm a member of the National Medical Advisory Committee of American Liver Foundation and the Executive Committee of the Greater New York MAC, and I'm excited to welcome you to the first virtual academic debates. The mission of the American Liver Foundation is to promote education, advocacy, support services, and research for the prevention, treatment, and cure of liver disease. Throughout the country, American Liver Foundation serves patients, caretakers, and healthcare professionals through mission delivery, which during normal times includes life educational programs, screenings, and health fairs. For the remainder of 2020, all our efforts have gone virtual. American Liver Foundation takes a leadership role in advocating on behalf of the millions of Americans living with liver disease by partnering with state and citywide organizations for different advocacy events, as well as taking part in national efforts in Washington, D.C. We'll share more information about this year's efforts towards the end of the evening. The fundraising dollars are reinvested in community programs, advocacy events, and provide funding for scientific research in the field of liver diseases. The American Liver Foundation staff relies heavily on the expertise of medical advisory committees throughout the country, as well as other amazing volunteers to ensure that they're providing cutting-edge information to as many people as possible. All of us here tonight are proud to be part of the American Liver Foundation's second annual academic debates for the Greater New York. While last year we had an incredible inaugural in-person event, this year's obvious situation has forced us to go virtual. We would like to take a moment to acknowledge the incredible, above and beyond work of every healthcare professional on this call. No one would have expected 2020 to turn into what it did. But what was no surprise was to see all of you step up to help, care for, comfort, and work around the clock as you did during the scary times of the pandemic earlier this year. We're happy you're okay and salute your efforts. While this year's academic debates are virtual, we are excited to cheer on the participating institutions. Thank you to every person who is watching and supporting tonight. As a reminder, the topics tonight do not have a right or wrong answer. The debater will be judged on criteria such as research of the topic and presentation skills by an outstanding panel of judges. As moderator, I will serve as the tiebreaker in event of a tie. I would like to introduce the wonderful judges for the evening: Dr. Ira Jacobson, MAC member from NYU Langone Health; Dr. Melissa Palmer, MAC member and CEO of Liver Consulting, LLC; and David Frank, Greater New York Leadership Council member and founder of NashAware.com. I would also like to take a moment to thank our generous sponsors. In Greater New York and throughout the country, we appreciate your support for all we do. Throughout the night, you will see their handles or links in the comment sections. They too will be doing some shout outs. Please be sure to check them out. We have our local sponsor, AbbVie, BioPlus, Dynavax, Exelixis, and Acta Pharma. We also have our national academic debate sponsors. Our national expo sponsor is Mallinckrodt. Our national bronze sponsor is CVS. And our national gold sponsors are Salix and ASI. Here are a few words from ASI. Now, I do encourage everyone to not only allow your competitive juices to flow tonight, but your generous ones as well. Thank you to everyone who donated when they registered. We've already raised just over $1,000. Throughout the night, you will see in our chat box a link to where donations can be made to support the mission of the American Liver Foundation. Please donate. As you might imagine, with the cancellation of every single in-person event, the American Liver Foundation needs your help. And we are aiming to see if we can raise $10,000 from this event tonight. Please make a donation today. And our first debate is a topic on transplantation and liver cancer. Should living donor transplantation be offered to patients with liver cancer that exceeds eligibility limits for priority on the deceased donor waiting list? Debating the proposition is Mount Sinai. Mount Sinai will argue that living donor transplantation should be offered to patients with liver cancer that exceeds eligibility limits for priority on the waiting list. Their mentors are Dr. Myron Schwartz and Dr. Augusto Villanueva. The fellow representing Mount Sinai tonight is Dr. Philip Haber. Debating the composition is Westchester Medical Health. Westchester Medical Health will debate the composition, arguing that living donor transplantation should not be offered to patients with liver cancer that exceed eligibility limit for priority on the waiting list. Their mentor is Dr. David Wolf. The fellow representing Westchester Medical Health is Dr. Sarah Olivier. Our timekeeper ready? You may begin.
So good evening, everyone. It's great to be here tonight and participate in a debate about such a current and important topic. So in the next few minutes, I will lay out why we believe that HCC patients exceed eligibility limits for priority on the deceased donor waiting list should be considered for living donor transplantation. For more than 2 decades now, selection of HCC patients for liver transplantation has been guided by the Milan criteria based on a series published in New England in 1996. These are defined as a single nodule no larger than 5 centimeters, or 3 nodules, none larger than 3 centimeters, in the absence of macrovascular invasion and extrahepatic disease. Adherence to these criteria will ensure an acceptable 5-year overall survival of usually above 75%. Rather quickly after the implementation of the Milan criteria, they were recognized as being too restrictive. So this has prompted considerable effort to define novel criteria able to expanding the pool of patients that might benefit from liver transplantation. So while generally advanced stage disease with macrovascular invasion and extrahepatic disease is considered a red line, the space in between Milan criteria and intermediate up to advanced stage disease has been the subject of much investigation. So new criteria have emerged incorporating more simple morphometrics such as size and the number of nodules, such as the UCSF criteria, but others have tried to account for the tumor aggressiveness and the biological behavior, such as the extended Toronto criteria, which simply require that the tumor does not show a dedifferentiated profile as assessed in biopsy. If these criteria are applied, survival rates somewhat comparable but slightly below Milan criteria are ultimately achieved. So this was recognized by UNOS, and thus downstaging criteria were established that align somewhat closely with the UCSF criteria. They are essentially guaranteeing that patients within downstaging criteria where a decent response towards a bridging therapy, such as TACE, is elicited and the tumor shrinks within Milan criteria, that these patients have a path to the deceased donor waiting list. Conversely, those patients beyond the downstaging criteria don't have that path at all. So this establishes a rather simple paradigm. Patients within the Milan criteria have access to the deceased donor waitlist and to liver transplant unless they drop out. Patients within the downstaging criteria have that access if therapy such as local regional therapy TACE is able to confer downstaging of the tumor to within the Milan criteria. However, if downstaging fails, that patient enters a palliative treatment trajectory with a thus markedly worse outcome. So this fails to account for some subpopulations of patients, however. So what about those cases that have an initial tumor burden beyond the downstaging criteria, but are successfully downstage to within Milan? So just because of where they came from, not because of where they land, they are excluded from the deceased donor waitlist. What about patients that are not eligible for downstaging therapies in the first place, even though they have a tumor burden within downstaging criteria? These patients, although they might be good candidates for liver transplantation and would have decent outcomes, are now subjected to a palliative treatment course with a considerably worse outcome. So when considering now if these patients might be suitable for liver transplantation, this of course has to be weighed against the risk of the donor, the concept of double equipoise. So current data globally hints at a general mortality between 0.2 and 0.5% of the donor. A study from the United States, the A2ALF multi-center cohort study that was published in Gastroenterology in 2008, reported a slightly higher mortality rate of 0.8%. Of note, 2 of the 3 fatalities were self-inflicted. A global survey that comprises more than 11,500 cases that was published in Liver Transplantation in 2013 reported a mortality rate of 0.2%. Likewise, here, psychiatric health was an issue leading to mortality as well. We, of course, also have to, in these cases, though, consider the morbidity and the impact this may have on the patient's life. Life-threatening complications were, in fact, reported in 8% of the A2ALF study among donors. So I think we can safely assume these numbers are substantial. So any benefit that is weighed against them must be equally substantial, if not much more. So for these purposes, I would consider 2 cases. So let's first consider a patient that has a tumor burden outside of the downstaging criteria. 2 nodules, one 8 centimeter, one 2 centimeter, and that patient is successfully downstaged to within the Milan criteria with TACE. The patient has a not very aggressive tumor, as accounted for by the AFP of 50, and well-compensated liver function with a Child-Pugh score of A6 and a MELD of 9. Now, because of where this patient started from prior to the downstaging therapy, the treatment this patient defaults to is a palliative one, TACE, where 5-year overall survival is expected to be around 32% based on a meta-analysis of phase 3 studies published by Riccardo Lencioni in Hepatology in 2016. Conversely, when the same patient is considered for living donor transplantation, which for him is the only other option to get on a curative treatment path, the patient has an expected outcome or an expected 5-year survival of 58% if we assume the morphometrics and use the metro ticket calculator to calculate this. And this is even without accounting for the viability of the tumor. If we consider the treatment effect and the tumor being downstage, this number goes up to the high 70s, so competitive with Milan criteria. This data is further corroborated by a multi-center phase 3 trial from Italy that was recently published in Lancet Oncology a couple of months ago. In this trial, patients, all comers, so with a tumor burden outside of the downstaging criteria and within the downstaging criteria, that were successfully downstaged to within Milan, were randomized to receive either transplantation, which in the Kaplan-Meier curves is in red, or control treatment, which is in this case TACE, and then subsequently systemic therapy. And I think it's clear that both for event-free survival and for overall survival, there's a substantial difference that is elicited by transplantation. So we can say here that there is a major discrepancy in the overall outcome based on the treatment that is assigned to the patient. So this is a patient that should be considered for living donor transplantation. Likewise, we can consider another patient who has an initial tumor burden actually within the downstaging criteria. So single nodule, no larger than 6 centimeters, also an AFP of 50, but markedly worse liver function with a Child-Pugh C10 and a MELD score of 22. Now this patient, I want to stress, has no other treatment option. He's not eligible for downstaging therapies in the first place, and likewise not eligible for systemic therapies of any kind. So for this patient, he defaults to BCLC stage D, where treatment of choice is best supportive care with an expected outcome of expected survival of a couple of months. Conversely, the same patient with living donor transplantation has an expected survival after 5 years of 50%. So likewise, this is a patient that we should consider for living donor transplantation. So our conclusions here are that there's a place for living donor transplantation at specialized centers for patients with HCC that are beyond the Milan criteria if the tumor burden is successfully downstaged to within Milan criteria independent of the initial tumor burden. Likewise, patients within UNOS downstaging criteria that are not eligible for downstaging therapies, be them systemic or intraarterial, should be considered as well. Of course, ultimately, there's an individual case-by-case decision where several factors have to be accounted for, such as donor risk, the tumor biology, and the specific treatment benefit that's expected.
Hello, good evening all. I'm Dr. Sarah Olivia, representing Westchester Medical Center. Thank you to the ALF for the invitation. And we're going to be presenting our arguments against living donor liver transplant for patients with liver cancer exceeding eligibility criteria. So the major drawbacks are a triangle based on donor safety, recipient outcome, and financial costs. Donor safety is based from the premise of do no harm. Subjecting a healthy person to the risks and burdens for the sake of another individual is remarkably unusual in a medical practice where the focus has been traditionally do no harm. That's a principle of non-maleficence. Since the first living donor liver transplant back in 1989 from adult to a child, we seem to have abandoned the do no harm concept. And now we wonder, how far do we go down this slippery slope? In terms of what are other possible complications leading or affecting the safety of the living donor, we see medical, psychological, that could include but not limited to pain, discomfort, future complications, strained family relationships, distress, depression, and the financial burden. The living donor surgery is a major surgery. Donors typically stay in the hospital 6 to 8 days post-op, with some period in the intensive care unit. The convalescent time at home ranges between 12 to 16 weeks, and the return to their normal activities go an average of 4 to 6 months. Is a large surgical incision, and the rate of complications seems higher in the adult-to-adult living donor series compared to a single-center series from Asia, and this was reported in 2016 by Kim et Testa. Other potential complications include DVT, pulmonary embolism, wound infection, biliary leak being the most common, and small for size syndrome. More commonly seen in donors of left lobe versus right lobe donors, with a 10 to 20% risk of complications, and sometimes multiple complications may happen in a single donor. The risk of death is 0.5 or 5 in 1,000 donors. In a report by Levitsky and Gordon in Liver Transplantation this March, we see that patients that are outside Milan or UCPS criteria tend to have higher recurrence rate of HCC with decreased survival, which makes the benefits of living donor liver transplant low and do not outweigh the risk posed to the donor. In terms of the non-maleficence principle to the donor, this prevents a donation that is not justified given the potential benefits to the recipient. There doesn't seem to be a consensus on an acceptable recurrence risk for the living donor transplant. Transplant teams may not respect the potential donor's autonomy if the recipient risk for HCC recurrence is too high or the prognosis is too poor. How far is too far in a desperate attempt to save a life? In terms of recipient survival, we must look at both donor and recipient outcomes on the post-liver transplant, and we have seen that leading to living donor liver transplant seems to be a faster track evaluation, not providing adequate time to assess the tumor aggressiveness. And the new liver seems to be a perfect milieu for the tumor progression in case of persistent occult tumor foci. The recurrence has been estimated between 11 and 35, and this is within inclusion criteria, so we're expecting it to be higher outside of this criteria, with a median recurrence of 20.5 months, and current national data shows slightly inferior patient and graft survival rates with liver donor versus deceased donor transplantation. Factors leading to recurrence, we have the growth factor that mediate the regeneration of the hemiliver after the liver transplant that can potentiate the recurrence, an aggressive or rapidly progressive HCC biology that may not be recognized during the decreased waiting time for liver transplant, technical challenges of the surgery, and the possibility that a previously ineligible transplant candidate could compete subsequently for a deceased living donor in the event of the donor graft failing, which is against the justice and fairness principle that we advocate for the allocation of donors and transplant. Going back to the double equipoise that Dr. Haber presented, this clearly represents an area of excessive donor risk and unacceptable low recipient benefit. And in this case, the decision being made, we have to, it is susceptible to include not only the mortality and morbidity data, but also quality of life, psychological and social considerations related to both the parties. In conclusion, we don't think this is ethically defensible for a living donor to undergo an operation with a mortality risk greater than expected rate of 0.5% as reported by centers around the world, nor it is acceptable for a donor to undertake any risk if the recipient benefit is predictably to be very low.
So that was a great presentation. There are a couple of points that I would like to make here that are, I think, warrant another perspective. I think we can all agree that sort of one of the major arguments that's been made is donor safety. And likewise, we can all agree that donor safety indeed is paramount. But there is a major trend towards an improvement in that regard. So the mortality statistic that I was showing earlier, a 0.8 mortality rate in the A2ALF study, and the 0.2 mortality within the global survey that was published in liver transplantation are numbers that we see decreasing right now. There are different factors that convey this. First, the onset of minimally invasive techniques. Dr. Olivier pointed out that there's a discrepancy in the mortality outcomes between the West and the East, and that's correct. One of the reasons is because of the East has had, especially South Korea, where living donor transplantation is in the driver's seat compared to deceased donor transplantation for ethical reasons, is that minimally invasive procedures have been at a much higher frequency performed there. Now, along with the general trend that minimally invasive liver resection conveys a better outcome with less morbidity and shorter hospitalization, they see the same trend when laparoscopic liver donation is performed. This was recently published earlier this year in Liver Transplantation in a series of 500 cases from AMC, subsequent cases. And among those, a mortality rate below 5% is accounted for by major complication Clavian-Dindo grading system was shown. And this is below the numbers from the A2ALF study. Now, certainly we see that trend shifting from the East going to the West, where now these laparoscopic procedures have been implemented here in select centers in the West, and we see this globally increasing now. So we do expect morbidity rates to come down. Also, this is with regard to psychiatric health that was just mentioned. This was reported in the American Journal of Transplantation in 2017 that in the A2ALF study that was cited here, that there was an impaired mental health in up to 10% of the donors. In fact, in the A2ALF study, 2 of the 3 fatalities were suicides. And likewise, in the international survey, there were 4 out of the 23 cases were suicides. Now, this impaired mental health that's in up to 10% of all cases published in AJT is sort of a gateway where outcomes can be improved through a better follow-up for the donor. And this is something, an effect that we already see. So if we consider the latest SRTR report that was published in the American Journal of Transplantation this year, that goes for the 4 preceding years up until 2018, we see that a single donor mortality was observed in the 4 years prior to 2018, within a year after donation. In the 4 years preceding that, so since 2011, there wasn't a single one, although more than 2,000 transplantations have been performed. So we certainly see that number decreasing. And as Dr. Olivier mentioned in her final slide, the cutoff of 0.5%, which they define as being sort of the red line that should not be crossed, we do see the numbers moving below that line. Finally, with regard to recurrence data, I would also point out that indeed living donor transplantation is not associated with a higher recurrence. The data from the A2ALF study where this was insinuated is based on that the patients with living donor transplantation had a markedly shorter time to transplantation, and thus the biological behavior of the tumor was not adequately observed. The authors comment on this in the discussion and concede that point. And subsequently, many trials have shown, including internal data from Mount Sinai that we published at ASLD last year, have shown that recurrence data between living donor transplantation and deceased donor transplantation is very similar. Thank you.
Well pointed by Dr. Haber. I will go back to the points of recurrence. We have still not gone beyond the decrease in the recurrence rate beyond criteria. And that is too much of a risk posed to the donors. Is it worth it for a donor to undergo this surgery, even if it's minimally invasive surgery and we're decreasing some of the morbidity attached to open surgery, for donating organ that has low benefit for the recipient with high recurrence given the tumor biology? the other part that I would like to discuss is also the morbidity associated to the psychosocial and then financial burdens to the donors, is that there's not any standardized guidelines on the psychosocial evaluation of the donors prior to donation. And that is where we have to probably work on the preparation for living donors a little better and make it across the boards to prevent the psychosocial burden and morbidity post-transplant. In terms of the financial cost, that is not, I didn't mention or limited the mention before. There's financial burden that is not being depicted as much in a lot of the data that is not associated directly to the transplant itself, but it's aggregated to it. Most of these donors have other costs attached to it in terms of traveling, in terms of not being able to work, and sometimes they are the main provider in their families. That also adds up to the psychosocial burden of being a donor. And these are aspects that we should bring into the evaluation of the donors and see how much of the risk of recurrence, the risk of the surgery is, where is the line of that risk could meet enough for the benefit for the recipient. And we should probably have more data in terms of this specific morbid mortality associated with the donors in prospective studies and multi-center studies in our countries. Thank you.
It looks like there are no questions at this time.
I have a question.
Go ahead, Dr. Jacobson.
Thank you. A question. First of all, wonderful job by both discussants. For Dr. Olivier, is any of your concern driven by the potential variability in the extent of full disclosure to prospective living donors of the risks? In other words, is the problem partly, in your view, that you think that potential donors might not be fully informed of all of these ramifications that you've laid out? Or if there were a uniform, incredibly transparent disclosure process that was the same nationally across the board, where we really had no doubt that donors were being fully informed of every aspect of this, would you be better with it?
So across the data that I reviewed, that was the main concern. There's not a universal standardized disclosure during the informed consent of the possibility of this risk, especially what is the death risk for a donor after the surgery. They use different numbers, they're variable in the tenfold, and not being universal leads a lot of way for the transplant teams to manipulate information in favor of the benefit for the recipient. And that's where the principle of autonomy for the donor comes is at risk, because you're sort of, in a way, by manipulating information vaguely and not being standardized, you're coercing the decision of the donor with a not complete or validated risk of the procedure for them.
Dr. Haber, without access to a deceased donor organ, how would you propose that people exclude coercion of the donor because their loved one has no other option, right? A part of the principle of living donation is the donor has to do it of free will, but if the recipient has no option for a deceased donor, it seems coercive.
Well, I would counter that the concept of no option is a relative one here. It's no curative option, it's true. It's not that, so in several cases, for example, the first case that I was laying out, there are certainly treatment options for the patients. Those are palliative, and they have a markedly worse survival. But nonetheless, they have different options. So the argument of coercion, I think, is there and can only be countered with a standardization of the consent that has to take place for patients, where globally applicable data is available. But I would argue the same way as Dr. Olivier, the standardization so far is not optimized. So this is something where there's room for improvement. But we also have to consider that if we paint a picture of donors being coerced, we also have to say that there are in fact many donors that would consider a transplantation or would consider donation, even if the outcome is worse than what is reported as this most frequently applied 50% threshold at 5 years. So it's a sword that cuts both ways, I think, but standardization sounds certainly like the way to go to improve this.
All right.
Yeah.
Thank you to our mentors and fellows. Congratulations to both teams. At this time, we will ask our judges to be placed in a private break room in order for them to compile their notes. In the meantime, we would like to once again thank our sponsors who have helped make this event a success. Your support is invaluable to us. And it's truly a pleasure tonight to welcome Dr. Robert Brown, member of American Liver Foundation's National Medical Advisory Committee and the chair of the Greater New York MAC. Welcome, Dr. Brown.
Thank you, Nadia, and welcome everyone. I hope you all enjoyed that first debate. I certainly did, and I think that this is at least making the best of our current situation by at least providing both educational opportunities for our fellows and for our audience. And it is fun to at least come together virtually to see what's happened to everybody's hair and at the same time be able to show off the best of our fellows' education and occasionally their home decor. But they really put in all of the work to make this shine. I can tell you as one of the mentors, I did almost nothing. And so we really want to give them our virtual congratulations. So shower up the positive emojis and show them their love. But also, as both an ALF supporter and as the chair of the Greater New York Medical Advisory Committee and the executive committee of the National Medical Advisory Committee, I have to highlight that this is a difficult time for the American Liver Foundation. We do most of our fundraising at in-person events. Those of you who've been to the Flavors event, all these wonderful things that bring people together and raise money for our important cause of research, education, and patient support for people with liver disease. So we need, even during these difficult times, to remember the ALF and to donate. So our patients are in more need. Every day we get phone calls about is my pre-existing condition serious? Can I go to work? Can I ride public transportation? And these are questions that the American Liver Foundation is helping our patients with every day, while at the same time trying to support the research that will decrease the burden of liver disease in the future and help us work towards our WHO goals of hepatitis elimination. So I hope that you will help give a voice to those patients and turn the light on liver disease through supporting research. The link to donate is in the chat box. We do want to get to the $10,000 mark. We know we started with 1,000, we're a tenth of the way there, but that's, if you think about a marathon, we still got a lot of hills to cross. But think about how much you've saved during the COVID. You know, I've saved at least $6 a day at Starbucks alone. Multiply that by 2 months, and I should be able to make a donation that will support the American Liver Foundation. Every bit helps. I'm so happy to see so many people signed on to the YouTube, fellows, former fellows who probably are making an income, incoming fellows who I probably would give a free pass, and the members of the faculty of the various institutions. So take what you would have paid for the dinner tonight and try to give to the American Liver Foundation. We would all appreciate it. And most importantly, I look forward to seeing the results of this first debate, but stay tuned for the second debate. I've heard at least one of the mentors is a snappy dresser. So it's going to be great, and I'm going to turn it back to Nadia.
Thank you so much, Dr. Brown. This is Lindsay Ventura. I'm a national manager for outreach and education here at the American Liver Foundation. We're just letting our judges have 1 more minute, so I'm going to be closing the breakout room briefly, but if you could all please, as Dr. Brown said, donate. We will be closing the room right now for the judges to encourage them to come back in. I did want to take an opportunity to just give an extra shout out to our sponsors. We really are honored to work with people who really care about our mission, our patients, the diseases that we work to bring more attention to, whether for prevention, research, treatment, whatever it may be. We are blessed to have these sorts of pharmaceutical partners. It's very important for us to have that sort of benefit to our patients. We want to give an extra shout out to not just the company, but to the individuals that speak with us and personally attend our events, ensure that we receive support. We want to thank you because we know you're watching tonight. From Eastside, we have Teresa Cronin, Eric Cintron, Tom Salmon. We're going to now I'm going to keep shouting folks out throughout the evening, but at this point, I am going to turn it back to Nadia Ovchinsky, our wonderful moderator this evening. And with
All right, and we are on to our second debate. The second debate is on a topic of NASH. Is NASH with advanced fibrosis an indicator for weight loss surgery? Debating the proposition tonight is Montefiore Medical Center, Albert Einstein College of Medicine. Montefiore will argue that, yes, NASH with advanced fibrosis is an indicator for weight loss surgery. The mentor is Dr. Samuel Siegel, and the fellow representing Montefiore is Dr. Victor Powell. Debating the composition is New York Presbyterian. New York Presbyterian will debate the position arguing that NASH with advanced fibrosis is not an indicator for weight loss surgery. Their mentor is very well dressed, Dr. Bob Brown, and the fellows representing New York Presbyterian are Dr. Allison Kaplan and Dr. Adam Buchholz. Welcome. Good luck.
Thank you for Thank you for the opportunity to present this topic. Is NASH with advanced fibrosis an indicator for weight loss surgery? So I will start with the agenda. Today I will be discussing that NASH with advanced fibrosis is associated with increased liver mortality, cardiovascular disease, and overall mortality. Bariatric surgery improves metabolic syndrome, improves liver histology, and decreases overall mortality. Bariatric surgery in NASH with advanced fibrosis is safe and effective. As hepatologists, we care for the whole patient. With bariatric surgery, not only are we improving liver histology, but we are improving weight and multiple metabolic parameters. Most importantly, the improvement is sustained. Advanced fibrosis in NASH predicts liver mortality. In a meta-analysis of 5 cohort studies with nearly 1,500 patients, it was shown that the risk of liver-related mortality increased exponentially with each stage of fibrosis. Advanced fibrosis in NASH also predicts cardiovascular disease. In an analysis of NHANES 3 data with nearly 2,500 individuals with NAFLD, NAFLD independently was associated with cardiovascular death after adjustment for major confounders. Advanced fibrosis in NASH also predicts overall mortality. Risk of all-cause mortality increases with increasing fibrosis stage. Major cause of death is cardiovascular for all patients, including those with cirrhosis. So getting to bariatric surgery itself, which improves metabolic syndrome. By decreasing weight, it decreases the severity of diabetes mellitus, improves hypertension, and improves hyperlipidemia. Bariatric surgery leads to weight loss and resolution of diabetes in 55 to 95% of patients, and this is sustained for greater than 2 years in the majority of patients. Bariatric surgery improves the control of hypertension after 1 year, resulting in a decreased number of antihypertensives. In this randomized trial, including obese patients using at least 2 antihypertensive drugs at maximal doses or greater than 2 at moderate doses, patients were allocated to either Roux-en-Y gastric bypass combined with medical therapy or medical therapy alone for 12 months. Roux-en-Y gastric bypass significantly reduced the number of antihypertensive medications that were required. Bariatric surgery also improves total cholesterol. In a retrospective review of 95 morbidly obese patients with documented hyperlipidemia who underwent laparoscopic gastric bypass, it was shown that weight loss after laparoscopic gastric bypass substantially improves lipid profiles in morbidly obese patients who have hyperlipidemia. And most importantly, this result was sustained at 1 year. Bariatric surgery also decreases cardiovascular events. In this prospective controlled study conducted on greater than 4,000 patients, bariatric surgery was associated with a reduced number of cardiovascular deaths. Now, most importantly, let's get to the liver. Bariatric surgery improves liver histology. In a study of 109 patients with liver biopsies before and at 1 year after bariatric surgery, NASH resolved in 85% of patients. The main predictor of persistent NASH 1 year after surgery was a lack of significant weight loss, further emphasizing the key role that a reduction in weight plays in improving histology. In a subsequent study, which also showed that bariatric surgery improves liver histology, in this study of 180 patients with liver biopsies before and at 1 and 5 years after bariatric surgery, it showed that F3/4 disease went from 38% down to 18% after 5 years. The resolution of NASH with no worsening of fibrosis occurred in 85% of patients 5 years after bariatric surgery. And at 5 years after surgery, BMI was reduced by greater than 10% in 61% of patients. The extent of weight loss influenced the rate of resolution, which was very important. A few pounds off that is not sustained is not good enough to have an effect on liver histology. Also, bariatric surgery decreases overall mortality. In this retrospective cohort of 33,000 patients, the study population included 8,300 patients who underwent bariatric surgery and 25,000 patients who underwent who went through non-surgical techniques. Bariatric surgery using laparoscopic banding, gastric bypass, or laparoscopic sleeve gastrectomy compared with non-surgical obesity management was associated with all-cause mortality over a median follow-up of a lower all-cause mortality over a median follow-up of approximately 4.5 years. So let's get to bariatric surgery specifically in advanced fibrosis. There's been about 10 studies published on this topic. Unfortunately, there's been no randomized trials, as this is very hard to do with this particular study. And they've mostly been retrospective studies and case series. Data is consistent, it is safe, and it is effective. For bariatric surgery in advanced fibrosis is safe. And this retrospective series of 13 cirrhotic patients with Child's A cirrhosis that were matched with 26 controls who underwent sleeve gastrectomy, it was shown that there were comparable outcomes in terms of length of stay, mortality, and complications. In this subsequent study that compared patients with minimal versus advanced fibrosis who underwent bariatric surgery, again, both groups were comparable in terms of in-hospital complications and complications up to 1 year out of surgery. So bariatric surgery in advanced fibrosis is also effective for weight loss. In this study, weight loss for patients with cirrhosis undergoing sleeve gastrectomy was similar to non-cirrhotic patients who also underwent sleeve gastrectomy. Bariatric surgery in advanced fibrosis with cirrhosis is effective for improving metabolic parameters. There were improved outcomes in terms of diabetes and weight loss up to 2 years post-surgery in this retrospective review of 14 patients with Child's A cirrhosis who underwent bariatric surgery, sleeve gastrectomy, or bypass. And most importantly, bariatric surgery for patients with NASH cirrhosis increases quality-adjusted life years and is cost-effective for patients with mild, moderate, and severe obesity. What are the alternatives to bariatric surgery? Weight loss via the traditional route, various diabetic medications, vitamin E, and obeticholic acid. So weight loss the traditional way presents a problem. First of all, you need a loss of greater than 10% body weight in order to see a regression in fibrosis. This is difficult to achieve with lifestyle intervention alone, personally, or if you have experience, you know this. And it's almost impossible to maintain. Only 10% of patients lose 7 to 10% of body weight, and fewer than half sustain the weight for 5 years. Alternatives to bariatric surgery also include various diabetic medications. Number one, they're chronic. You have to take them for lifelong, and they're not curative. Vitamin E is problematic in cirrhosis and diabetes mellitus, and again, does not have very good data for improvement in liver histology. And obeticholic acid, which is in the pipeline, is also chronic. It's not curative. There's side effects, and it increases cholesterol level. So what we need to think of when we're approaching patients with NASH with advanced fibrosis is we need to have a holistic approach. Fatty liver disease is a systemic disease. Bariatric surgery improves overall well-being and survival. We must question the benefit of a therapy that only improves liver histology, but the patient proceeds to die from cardiovascular disease or diabetic complications. In conclusion, bariatric surgery in advanced fibrosis/cirrhosis shows an improvement in metabolic syndrome and complications.
I wanted to extend my warm welcome to everyone today to the 2020 Greater New York Academic Debates. To remind you of our topic, NASH with advanced fibrosis is not an indication for weight loss surgery. So what does it mean to be an indication? The FDA has actually set forth guidelines for what they consider to be an indication. First and foremost, an indication must reflect the scientific evidence accurately. Second, it needs to include the scope of the approved indications, including the population to which the determination of safety and effectiveness is applicable. Third, an indication for a broader population can be appropriate if there is generalizability of evidence. So in summary, a study must reflect the scientific evidence, be applicable to the population in which it was originally determined safe and effective, and be generalizable if applying more broadly. Having reviewed these definitions, what are the current indications for weight loss? As you can see here, all of these indications have a BMI greater than 30. You need to be obese to have bariatric surgery, and the more obese, the stronger their indication. In the absence of obesity, there is no evidence for bariatric surgery. So NASH with fibrosis without obesity is not an indication. We argue that it's inappropriate to expand the pre-existing indication for bariatric surgery to all of NASH with fibrosis because there is a large group of patients with NASH with advanced fibrosis without obesity, what we call lean NASH or NAFLD. All previous studies were conducted on those for whom there's already an indication due to their obesity. And those patients had such severe obesity that they might not apply to most patients with NASH with advanced fibrosis. Those who benefited were those who lost a significant amount of weight, which may not apply to even the average patient with advanced fibrosis and NASH. And there are no controlled studies evaluating the efficacy of bariatric surgery against medical management. So let us review lean NAFLD NASH. It's incredibly common, estimated at 7% in the US and up to 19% in Asia. There was a large Japanese study with biopsy-proven NAFLD that found a prevalence of non-obese NAFLD to be 25% in men and 40% in women, despite a stringent BMI cutoff of 25. On biopsy, when stratified by BMI, the rates of advanced fibrosis were high among those with low BMI. We can still see rates of 31 in the lowest BMI category. And in women, the rates of fibrosis were actually somewhat inversely correlated with BMI, with the middle BMI category having the highest rates of fibrosis. Additionally, obesity is only one associated factor with advanced fibrosis. This is a study of biopsy-proven NAFLD that showed that those without obesity, but with metabolic syndrome, had similar rates of advanced fibrosis to those with obesity. Here we see the non-obese metabolic syndrome patients with high rates of fibrosis compared even to those who are obese. And metabolic syndrome is incredibly common across all races and ethnicities. So taken together, these studies suggest that despite having low body weight, many patients with NAFLD NASH have advanced fibrosis, calling into question the utility of bariatric surgery for their disease. If you're not obese, you likely don't need bariatric surgery. Existing data supporting bariatric surgery doesn't apply in a non-obese population. As our opponents already tried to convince you, in the largest meta-analysis evaluating bariatric surgery for advanced fibrosis, an overall positive effect was undoubtedly noted. However, this study had several pitfalls. There was new or worsening NAFLD that occurred in 12% of patients, which is not an insignificant number. Studies excluded those with advanced fibrosis, which is the population we're speaking about. The baseline BMI at enrollment in all of the studies included in this meta-analysis was 49, which is significantly higher than most patients with NASH with advanced fibrosis. The median follow-up was only 15 months, and all studies were single arm. There were no randomized control trials and no studies with a comparator. Our opponents also presented this data. What about the longest prospective study of 180 severely obese patients with biopsy-proven NASH? The data looks promising. Only 16% had persistent or worsening NASH, or worsening fibrosis. However, as in the meta-analysis, the BMI prior to surgery was incredibly high. And again, this was their indication for bariatric surgery and may not capture those with NASH with advanced fibrosis and lower BMI. In subgroup analysis, those who did not have resolution of NASH and or had worsening of fibrosis, seen here in this column, were the ones that didn't lose as much weight, so decrease in BMI to 40.9 compared to 35.3. But even in this group, there was still a significant decline in BMI. So this calls into question the value of lean NASH with advanced fibrosis as an indicator for bariatric surgery when these patients don't have much weight to lose. Importantly, we would be remiss not to mention that in addition to the predictable complications associated with bariatric surgery, there is data to suggest increased mortality at 10 years in patients who underwent bariatric surgery with NASH. This is a study conducted out of Switzerland that was propensity score matched with the NHANES cohort. What they found was a hazard ratio for mortality that was 5.1, and the significance persisted in multivariable analysis. Looking at the data a different way, this is a survival curve that shows decreased survival in those with NASH compared to non-NASH. All of what we have shown demonstrates that we do not have evidence right now for NASH with fibrosis as an indication for bariatric surgery. This randomized control trial will hopefully help to clarify some of the issues we have raised about the generalizability of current data by looking at non-severely obese patients. Still, however, it doesn't include those with lean NASH. So is NASH with advanced fibrosis without obesity an indication for bariatric surgery? We would argue no. While the subpopulation of NASH with obesity have good evidence for benefit from bariatric surgery, the data is not generalizable to all of NASH with advanced fibrosis. Therefore, we conclude that taking into account the FDA's definition of an indication, that NASH with advanced fibrosis in and of itself does not meet criteria to be an indication for bariatric surgery.
Thank you for that presentation. I would want to bring up a few points that my colleagues have presented. So number one, the vast majority of patients with NASH are obese. And what I am advocating, what we are advocating, is not for surgery in patients who are non-obese. This is not something we're advocating. All the data we were talking about was in obese patients. So I want to bring up one point that was made in the presentation about the meta-analysis that showed histological worsening in non-alcoholic fatty liver disease. So 12% of those patients developed de novo or worsened non-alcoholic fatty liver disease after bariatric surgery, it was shown. However, this figure was reported with less precision than the benefits. In addition, in all these studies, there was no control group, and it was shown that some of these patients who developed worsening NAFLD were actually drinking, and we don't know if they, and most of them did not have successful weight loss. And also the largest prospective cohort study of patients with NAFLD that that showed a reported risk of worsening of fibrosis at 5 years. This study, again, is also frequently misinterpreted. Number one, the worsening of fibrosis at 5 years was slight, and the fibrosis score of 95% of patients at 5 years or later was still F1. Also, most of the patients in this study, greater than 90%, did not have NASH. So one question I want to ask, which wasn't brought up in the initial presentation, is what are the alternatives to bariatric surgery and NASH? And I'm talking about patients who are obese. Vitamin E, but again, as I brought up, a meta-analysis that included 5 trials found no histologic benefit with vitamin E, and dietary supplementation with vitamin E is significantly increased with the incidence of prostate cancer in some studies. Another alternative is pioglitazone. The use of pioglitazone is limited because it is associated with increased risk of weight gain, heart failure, and fractures. It is likely that the long-term treatment is required to achieve a clinically important benefit because improvements seen with pioglitazone may reverse once the drug is stopped. Pioglitazone is usually discontinued with advancing diabetes once insulin is required due to reduced efficacy in comparison with other combinations. And as far as OCAs is concerned, as I mentioned, there's been reports that it increases cholesterol in a majority of our patients that are, and many of our patients that are already obese. So we have to be realistic. The many patients we take care of live in food deserts. They do not have access to nutritionists, gyms, or pools. Bariatric surgery is the best way to lose weight, keep it off, improve their metabolic parameters, and prevent progression of their liver disease, all of which is our ultimate goal. And again, all medical indications that we have in practice today were at some point not indications. I have presented the evidence for why bariatric surgery for advanced fibrosis should be an indication for bariatric surgery, and I'm confident that in the near future it will be an indication. Thank you.
Before we get to our counterpoints, I wanted to thank Dr. Powell and the team from Montefiore, as well as the American Liver Foundation, for putting on this debate. And I think the points that Dr. Powell brought up are excellent ones, but it's always important to keep in mind the actual prompt here, which is that the indication for bariatric surgery should be advanced fibrosis. And as our initial presentation said, we're not going to argue that those who are obese and already have an indication couldn't benefit or wouldn't even benefit from bariatric surgery, and that it's not even largely safe in this population. Our argument is that in order to call something an indication, it has to be separate and sufficient from what's already existent. So for example, when you have a patient with a new diagnosis of advanced fibrosis in your clinic, when you're considering whether or not you're going to refer that person for bariatric surgery, your first question and your foremost question should always be, is that patient obese? When it comes to alternatives, the data that Dr. Powell presented suggesting that alternatives are not great thus far in this population. The lack of successful alternative doesn't an indication make. And what we have to prove is that bariatric surgery is safe and effective such that it can be indicated in all patients with NASH with advanced fibrosis. While the vast majority of patients with NASH with advanced fibrosis are obese, we've demonstrated that there's a significant proportion that are not. And we have to keep in mind that you have to make an indication based on the extant data. And the extant data suggests that bariatric surgery is safe and effective for those with BMIs of 40, 45, and 50. Even though the vast majority of patients with NASH are obese, the vast majority don't have BMIs of 45. And I think that while the worsening of fibrosis isn't severe, what we meant to do is call into question, who is it that's going to benefit at the end of the day from bariatric surgery with advanced fibrosis? And it appears to be those who have the most weight to lose. A BMI drop of 12 is not achievable with bariatric surgery for even all patients, certainly not only those with only moderate obesity. And finally, Dr. Powell brought up a good point that bariatric surgery improves many aspects of the metabolic syndrome. However, in a recent August New England Journal of Medicine study by Yoshino et al. At Washington St. Louis, they looked at possible added benefits of bariatric surgery, which is a hot topic in addition to the weight loss. Those include hormonal effects, and they looked at it in a diabetic patient population. And what they found when they matched patients to either weight loss with diet or weight loss with bariatric surgery is that they lost about the same amount of weight, and with the same weight loss, they had exact same improvements in insulin sensitivity, beta cell function, and 24-hour glucose and insulin levels. And so there may be a positive effect of bariatric surgery outside of the weight loss itself. Their argument just recently for a much better studied patient population with diabetes is that it's the weight loss specifically that leads to the improvement in the other metabolic parameters and nothing else. Therefore, we would argue that without data, as Dr. Powell noted, there's not a comparator groups in all of these studies. Without sufficient data, and especially looking at the groups with only moderate or lean NASH, moderate obesity or lean NASH, it's difficult to extend an indication of bariatric surgery to all patients with NASH with advanced fibrosis. Thank you for your time.
That was great. Congratulations, Victor, Ali, and Adam. There are a couple of points I thought about during your presentation. So there are definitely benefits to our virtual presentation tonight. We're able to actually discuss NASH, severe obesity, and weight loss without any guilt. Imagine how terrible we would feel right now in an in-person event, eating dinner and drinking cocktails. So this is definitely a benefit. And number two, when we run over time, we don't have to wave and try to get people's attention to stop them. We can just turn off their video. Sorry, Victor, our timekeeper was very strict. So we will now move to our questions and answers. Looks like there are no chat questions at this time. So I will ask our judges to ask the questions. Dr. Jacobson?
Yes, thank you. I also agree, terrific discussion by both sides of a very important topic. You know, to me, this debate gets down to what the AASLD guidance stipulates. It was published in early 2018. and I'm paraphrasing, but they essentially said, thou shalt not offer bariatric surgery to a patient with a primary indication being NASH with fibrosis, which I always found rather odd because it relegates it to a kind of fringe benefit when you discuss all the other advantages of bariatric surgery with patients. My question for you is, would you maintain that that is still a valid position to take if we limit the phrase to obese patients who have failed other interventions? Or would you concede the point that it's reasonable to offer these patients bariatric surgery with NASH and fibrosis as a primary indication on the same platform in terms of advantages offered to the patient's prognosis as the cardiovascular issues and the diabetes issues?
It sounds like that question is likely for our side.
I'm sorry, I should have clarified. That is for your side. And then I do have a question for the other side.
Sure. So we do concede that for those with obesity, bariatric surgery is almost certainly helpful and safe for management of their advanced fibrosis. I think what we're trying to get across with the data that we presented is that there's multiple phenotypes to the patient that has advanced fibrosis. And some of those are certainly going to have morbid obesity, and the best way to control other factors related to their obesity is with bariatric surgery. However, what we saw specifically in the data that suggested that the rates of fibrosis in those with metabolic syndrome in the absence of obesity suggests that there are plenty of patients that don't have obesity as a primary driver for their steatohepatitis and subsequent fibrosis. And we didn't present that data here, but that paper also found that those that had the more lean phenotype of NASH were those that had PNPLA3 genotypic changes. And so I think what we would concede is that in patients where you felt that their obesity is a primary contributor to their inability to get their metabolic syndrome under control, they would likely benefit from bariatric surgery. However, in the large number of patients for whom that's not the case, we think that there are safer and better alternatives. And if there aren't, we still have no evidence that bariatric surgery truly is going to benefit them.
Nadia, can I ask a quick question for Dr. Paul?
Yes, of course.
Thank you. I didn't want to take other judges' time. But Dr. Powell, nice job also. The issue I want to ask you about is, oh, my mind is escaping me for a moment. Oh, yes. The point about cirrhosis, you know, when we use the phrase advanced fibrosis in these kinds of discussions at a little bit of our peril, because it's not always clear what we mean. Are you putting advanced fibrosis and cirrhosis on the same platform? The numbers you showed for cirrhosis in the studies were very small. I recall seeing one slide with 13 patients, another slide with 14 patients. Do you really believe that we're ready to put NASH with cirrhosis as a primary indicator for surgery in these patients without more studies demonstrating long-term efficacy and safety?
So I'm advocating that we should do surgery for patients with advanced fibrosis / cirrhosis. It's like sometimes it can be difficult to distinguish, but in early child's A cirrhosis, bariatric surgery in an obese patient is a reasonable option. Yes, I can see that there aren't any trials with a large number of patients. This is going to be probably almost impossible to do, to have a randomized study of that nature. But out of all the evidence I did see in patients with early cirrhosis, they did well post-bariatric surgery. And a very, very subset of patients, anecdotal evidence, who happened to have portal hypertension that was either discovered later, even then they were able to manage their complications and the rate of mortality is low. So when I say bariatric surgery for advanced fibrosis and cirrhosis, I am talking about early cirrhosis, obviously, child's A, and I do think these patients would benefit. But,
and are you including patients with clinically significant portal hypertension or no?
No, that's not something I would advocate for, but I'm just saying anecdotally, I came across a few studies that did have a very single-digit number of such patients, and they also did well, but that's not something I would advocate for, considering we don't have enough data on that.
Okay, thank you.
I think Nadia, yeah, hi. So hopefully you can hear me. So the question, I have two questions. One, Dr. You both did very well, congratulations. Dr. Paul, you've mentioned a few times that randomized controlled trials would be difficult, if not impossible, to do in this patient population. So I wanted you to comment on that. And neither of the presenters, or all three presenters, mentioned about the 50 plus randomized controlled trials or trials that are going on with new medications as an alternative. So are there, do you feel that the risks of going into a trial outweigh the benefits of going into a trial? That wasn't discussed, because that's certainly another option, certainly in my mind. So I have those two questions.
So, I mean, I think it's reasonable to have a prospective trial in patients with early child's age cirrhosis. Everything we have right now are retrospective. Some of them are surgeons who have done 3,000 surgeries that come across cirrhosis during the intra-op period, and they, write up a case series on that. And all of them have shown, most of them have shown good outcomes. So I think it is reasonable to start doing this. It's just, as with all clinical trials on cirrhotic patients, it's surgery in cirrhotic patients, it might be difficult to start up, or people may be hesitant, but I think it's something that should be looked at very closely down the road.
Thank you. And then the question about the 50 plus trials that are ongoing as an alternative to bariatric surgery. That was
Again,
discussed by either group, yeah.
Yeah, it's, from what I understand, a lot of those trials are early, and the one about obeticholic acid, the results haven't been that promising. So I think it's time that we sit down and really consider making bariatric surgery in NASH with advanced fibrosis in obese patients an indication, rather than continuing to wait, because we've all seen the outcomes of these patients who fail medical therapy and what can possibly happen. Someone we have in the service right now developed HCC. These are all things we need to worry about. So I don't think we can keep waiting.
Dr.
I think the point is well taken, Dr. Palmer. I think that the point actually brings up the need for the randomized controlled trial that Dr. Kaplan mentioned in her initial presentation. And when drugs are considered for an indication, the expectation of the FDA is that the burden of proof is there, that you've shown how it works in a certain patient population and with a comparator group. And I think that the danger for adding an indication for advanced fibrosis to bariatric surgery in the absence of that data is that you may push patients away from considering other options. You have to be certain that you have shown both efficacy and safety as well as comparative effects in order to have an indication. And I don't feel that that burden of proof has been met yet by surgery. And we should hold it to similar, if not the same standards, to the burden of proof that we hold drugs to. And all of the drugs that are currently putative for treating fibrosis have to say, this is why it works. And the reason that bariatric surgery works is it works for obesity. And so before we extend the indication, I think we need to have better data. So I agree with your point.
Thank you.
And just remember, you're still encouraged to submit your questions in the chat box on YouTube. We have one comment from Dr. Andrew Delatorre that you guys did an excellent job. And how would you consider populations with a high prevalence of PNPLA3, putting them at risk of worsened fibrosis?
So if they do have this predisposition with the PNLAP3 gene, they're obese, that's probably even stronger push that these patients should get, especially if they're obese, should get bariatric surgery. They have a more aggressive course and develop fibrosis faster. So this is in parallel to what I'm advocating for, that these patients should definitely get bariatric surgery. Probably it should be looked at even more closely in such patients.
I agree that these patients need more aggressive management. However, the data that we've seen suggests that the populations that have higher prevalences of PNPLA3 mutations, and those include Asian populations as well as Hispanic populations, their rates of having lean NASH and lean NAFLD are higher. And therefore, the absence of, the fact of PNPLA3 and our improving understanding of its impact on worsening the fibrosis further shows the need to have a more defined indication for bariatric surgery in this population, just given the fact that there are all these different phenotypes and different contributing factors besides just obesity. And we've seen in diabetes data that when you do bariatric surgery with diabetics who are not morbidly obese, their rates of recurrence of diabetes are quite high. And so if you consider that patients that have even low levels of obesity and advanced fibrosis, they may actually have some regression, but if weight loss is not achievable and sustainable in the long run, especially those with PNPLA3, they're more likely to progress again.
All right, perfect. Looks like we have no questions at this time. Again, thank you so much to our fellows and our mentors. This was great. Congratulations to both teams. Again, at this time, we'll place our judges in a separate breakout room and give them a chance to compile their responses. Again, thank you to our sponsors. Despite this virtual platform, you have helped to make this event very special and successful. We appreciate your support, especially during these difficult times for American Liver Foundation. And please don't forget that we're still hoping to raise $10,000 tonight. If you haven't already done so, please be generous and try to donate now. You can find the link in the chat box. All donations are 100% tax deductible. Remember that you are supporting a great cause. Our patients, our communities need American Liver Foundation support today more than ever. So please be generous. Our annual American Liver Foundation Advocacy Day is virtual this year. So we're excited for the possibilities of having even greater impact than ever before and having more advocates join us. Training will take place on September 30th, and virtual visits will take place throughout the week of October 5th through 9th. These should be interesting pre-election times in Washington, D.C. So invite your colleagues and patients to join us. Register today, and you will find the link in our chat box. Few more announcements. In the greater New York area, one of the most beloved events is our annual Rebirth Day. Normally taking place in Long Island, this year's virtual event will continue to be a beautiful celebration and educational event for all the patients who have received a liver transplant, their caretakers, healthcare professionals, or anyone who just wants to be inspired. And it's truly an inspiring event. If you've never been to one, please try to make it since it's virtual this year. Dr. Sandy Foreman from Mount Sinai will be speaking. Again, please find more information. Just click the link in the chat box and join us. Thanks to those of you who joined us virtually for our regular spring annual Liver Life Walk. While we had our patients representing our hospital teams, we had many healthcare professionals who couldn't attend due to all the spring events. We're 2 weeks away now from the start of our fall virtual Liver Life Walks. Every Thursday, beginning on September 24th, we'll host activities based on one of the following themes: self-care, movement, exercise, cooking, crafts, and of course, liver education. The registration is now open. In case you missed the spring one, please join us for the fall events. And this is a very special, first of a kind event. On November 21st, we will have our first virtual Cuisine for a Cause. It's a virtual experience that will offer unique local and national engagement opportunities for the liver community and for that hidden foodie in every one of us. It will bring 2 seasoned top chefs personally into your kitchen. This fun and interactive culinary cook-along will inspire you to follow step-by-step instructions from our top chefs as you prepare, along with them, a HelloFresh signature dish. And hopefully it will not worsen our NASH or obesity. During these challenging times in the world, there's still a lot going on at the American Liver Foundation. Since the pandemic and our virtual transformation, this is now one entity. So please be sure to follow us on social media to stay up to date with all the efforts of the American Liver Foundation.
Hi, everyone. This is Lindsay Ventura joining you again. Our judges still need a little time. I guess that last debate was just a little too close for them to easily make a decision. So in addition to all the shout outs we've been doing on our live chat to our wonderful pharmaceutical partners, we'd also like to give a huge shout out to the entire Greater New York Medical Advisory Council. We couldn't be more in debt to you guys. You have been involved in every aspect of this program, the academic debates, from choosing the topics, inviting our hospital fellows to take part, helping us promote the event, and in the process, the American Liver Foundation. We are so excited to continue working with our Greater New York Medical Advisory Council. Well, you may have seen the notice a little bit earlier from Dr. Ovchinsky. She was discussing our Advocacy Day. I just wanted to briefly touch on this. This year, we do have the ability to bring an unlimited number of voices to be heard by our elected officials because we are advocating virtually. Every year, we do invite our constituents and supporters. We bring a huge mass of patients out to the Hill Day and have them speak with their representatives. And, you know, this year we can bring as many people as we want. I've actually been able to go to the Hill for a few different years for Advocacy Day, and it really is powerful. As somebody who's had liver disease myself, and somebody who's watched my mother get a liver transplant, to be able to share our story and share the importance of the ALF in our advocacy work, and especially our legislative priorities is wonderful. So I'm pleased to say that our judges have returned. At this time, I'm going to pause myself and we're going to bring everybody from the debates back up.
All right, welcome back, everyone. The judges are now ready to announce the winners of each debate. Dr. Jacobson?
Yeah, thank you, Nadia, and thanks to everyone who participated in this wonderful experience. Congratulations to Veronica and the ALF for putting on another excellent program. Everybody was very well prepared, and I hope everybody understands this isn't an easy decision for us judges. It was certainly an honor to be involved. I feel a little bit like somebody who's watched the 5th set tiebreaker of a Grand Slam tennis match, championship round, and you just say to yourself, it's a shame somebody has to lose. Let me go through the criteria that we used to render our judgment. So the fellows were judged on their presentation skills. Citation of appropriate literature to support the case was important. Summation of their case, and of course, audiovisual content and style. The rebuttals were based also on presentation skills, the degree of effectiveness of rebutting the opposing position, effectively supporting their own position, and of course, how they handled the questions and answers. And so I'll ask Dr. Palmer to share with us the identity of the winner of the first debate and Dave the second.
So, hi. So I think that, again, it was a very difficult decision. Both presenters did an excellent job. Nadia did an excellent job moderating the session, and we do thank the American Liver Foundation, Lindsay, Kat, Veronica, everybody else who was helping out, did a great job. But we do have to announce a winner, and this was Mount Sinai. Did an excellent job, and certainly, Westchester also did an excellent job, but Mount Sinai is the winner on this debate. Thank you.
Great. Thank you, Dr. Palmer and Dr. Jacobson. And again, congratulations to the teams at New York Presbyterian and Montefiore. These were some interesting questions where I think that maybe the conventional wisdom didn't always prevail, and great debates by both teams. The second question is NASH with advanced fibrosis, an indicator for weight loss surgery. And the winner in this particular debate was New York Presbyterian.
Congratulations to all who participated tonight, especially to the fellows who, despite our virtual platform, have done an amazing job. And congratulations to the winners of tonight's debate. Again, first virtual debate, so you are really pioneers. Thank you again to all our sponsors. Thank you for supporting this great cause and for supporting our debates. There's still time, guys, to help American Liver Foundation reach our fundraising goal of the night. Please donate if you haven't done so already. And if you had a great time on our virtual platform tonight, please join our next academic debates on Saturday, September 26th in the morning. Will be part of the District of Columbia academic debate. Registration is open now, so please feel free to register. Thank you, everyone. Thank you, everyone, for supporting and watching. Thank you again to our wonderful participants, to our sponsors, and to the American Liver Foundation for making these debates possible for us, rescheduling it from our original date in March, and not doing this over dinner. Please stay safe, everyone. American Liver Foundation and all the participants, you are so important to our patients and our community. Thank you for all you do. We will see you at the next debates.